Welcome back to the Deep Dive. Today, we're plunging into a really crucial stack of sources, basically a comprehensive overview of critical care conditions and concepts.
Yeah, it's just some dense stuff.
Exactly. And our mission, to give you a shortcut, a clear path through all that detail so you can quickly grasp the most important information about these really serious medical situations.
We're going to try and pull out the key features, how things are diagnosed, the essential treatments.
And importantly, what complications you really need to watch out for.
And we want to go beyond just listing facts, right? We want to help you understand the why these things happen, why the treatments work. We'll draw out those vital distinctions and maybe some surprising connections that matter when things get critical.
Think of us as guides, basically.
Yeah.
Helping make sense of it all. Okay, let's unpack this. Where better to start than metabolic emergencies, specifically the big two in diabetes, DKA and HHS?
Good starting point. They both involve high blood sugar, yeah, but they are profoundly different problems underneath.
So let's break down diabetic ketoacidosis, DKA, first.
Okay. DKA and then hyperosmolar hyperglycemic state, HHS.
Yeah.
Both diabetic emergencies, both high glucose, but the metabolic chaos, totally distinct.
Right. So for DKA, the sources describe a pretty rapid onset.
Yeah.
You often see that characteristic deep, rapid breathing. Cosmal respiration.
Cosmal, yeah. The body's trying desperately to blow off acid.
And that fruity breath people talk about from the ketones.
That unmistakable acetone smell, exactly. Patients feel really sick too. Nausea, vomiting, abdominal pain, and the significant dehydration, plus maybe altered mental status.
Okay, and the labs for DKA, what confirms it?
Well, glucose is usually over 250, yeah, but the key is the ketones. You find them in the urine or blood. And metabolic acidosis, so a low pH, typically below 7.3, and low bicarb HCOs below 18.
And a high anion gap.
Right, that reflects all those extra acids building up. Now, here's something interesting the source points out. Potassium. K-plus acid. It can be high, normal, or low initially, even though the body's actually lost a lot of potassium overall.
Why is that?
It's the acidosis and the lack of insulin action. They push potassium out of the cells into the blood, so the initial blood level can be misleading.
Gotcha. So fixing DKA means tackling the dehydration and the acidosis head on.
Exactly. Treatment starts with aggressive IV fluids, usually normal saline first, just to get volume back up. Then you add IV regular insulin. That stops the ketone production and helps drive glucose back into the cells.
And the potassium.
Oh yeah, potassium replacement is almost always needed. As the fluids and insulin work, potassium gets pushed back into the cells, and you can get dangerously low levels hypokalemia.
So constant monitoring is critical. ABGs, glucose, electrolyte.
Absolutely. And a cardiac monitor, definitely, because those electrolyte shifts can cause arrhythmias.
And the risks if things go wrong.
Well, the source really emphasizes cerebral edema swelling in the brain, especially in kids. That's something you absolutely have to watch for. Other big ones are that dangerous hypokalemia we mentioned, arrhythmias, shock, and sadly even death if it's not managed quickly and correctly.
Okay. Now let's pivot to HHS. Hyperosmolar hyperglycemic state. This one's different, right? Slower onset.
Much slower, yeah. Often develops gradually over days, even weeks sometimes. And the most striking feature, profound dehydration. Just massive fluid loss.
And the mental status.
That's often much worse in HHS. Patients are typically much more confused, maybe even comatose. Neurological symptoms are really prominent. But crucially, you don't see the cosmal breathing because there isn't significant acidosis.
And no fruity breath.
Nope. Because ketone production is minimal or absent, it tends to happen more often in older adults, maybe with underlying kidney issues or an infection triggering it.
So the labs tell a different story too.
Completely. Glucose levels are sky high. I mean, often over 600, sometimes well over 1,000.
Wow.
And the serum osmolality is way up over 320 METOS and MISM. That tells you just how concentrated the blood is from all that water loss and high sugar. And that's what's driving those severe neurological symptoms.
But the pH and bicarb?
Usually normal or close to it. No significant acidosis. BUN and creatinine are usually high, though, because of that severe dehydration hitting the kidneys.
Treatment for HHS? Still fluids.
Fluids are absolutely key, yes. Often start with normal saline, but then might switch to half normal saline to more gently correct the high sodium that often comes with losing so much water.
And insulin.
IV insulin, yes, but often at a lower dose than for DKA. The main goal isn't fixing acidosis here, it's gradually lowering that extreme glucose and osmolality. Potassium replacement as needed, of course.
And you mentioned monitoring neurostatus is paramount.
Absolutely. And the source is stress slow correction. Bringing the glucose and osmolality down too fast can cause dangerous fluid shifts in the brain.
What are the big complications with HHS?
They can be really severe. Seizures, blood clots, thrombosis, because the blood gets so thick and sluggish from dehydration, coma.
Yeah.
And unfortunately, the mortality rate is actually higher than in DKA.
Really? Why is that?
Often because the patients are older, they might have more underlying health problems, and the condition has often been developing for longer before they get treatment. That high serum osmolality, that's your big warning sign for how dehydrated they are and the risk of those CNS issues.
Okay, before we leave diabetes, one really practical thing from the sources: the sick day rules. This is about prevention, right?
Hugely important. This is how you can potentially stop DKA or HHS from happening when someone with diabetes gets sick with, say, the flu or an infection.
So what's the core message?
The absolute #1 rule: never stop taking your insulin or diabetes meds, even if you feel sick and aren't eating much. Your body still needs it, especially when stressed by illness.
Okay, what else?
Check your blood glucose much more often, like every 2 to 4 hours. If it's high, say over 250, check for ketones using urine strips or a meter if you have one.
Hydration.
Crucial. Keep drinking fluids, water, sugar-free drinks. If you can't eat meals, try to sip on small amounts of liquids with carbs.
And when do you call for help?
Know the warning signs. Call your doctor or go to the ER if you're vomiting and can't keep fluids down, if you have moderate or large ketones, or if your blood glucose just stays really high, like over 300, despite following the rules. These steps can literally be lifesavers.
That is such a concrete, actionable takeaway. Okay, let's shift gears. Airway and breathing emergencies. Opioid overdose, a classic acute one.
Right. The sources highlight that key triad of signs. Respiratory depression breathing is slow, shallow, maybe stopped altogether, pinpoint pupils, and a decreased level of consciousness, maybe unresponsive.
You might also see cyanosis, that bluish skin.
Yes, indicating low oxygen level.
An immediate fix.
Naloxone, that's the opioid reversal agent. Give it quickly, IV, IM, or the nasal spray works fast too. And crucial, airway support. Maybe just repositioning the head, maybe needing bagging, or even intubation if they're not breathing.
And you have to watch them closely afterwards.
Absolutely. Naloxone wears off faster than many opioids, so the respiratory depression can come back. They might need repeat doses. You have to monitor them carefully.
And watch for withdrawal too, I guess.
Yeah, as the naloxone kicks in, they might go into withdrawal, which can be unpleasant, but usually isn't life-threatening like the overdose itself. Okay, so to understand breathing better, especially in critical care, we need to talk ABGs.
Arterial blood gases.
Right.
They give us those key numbers. pH acid or alkaline?
PaCO carbon dioxide, which reflects ventilation.
HCO is bicarbonate, the metabolic part.
And PaRO, the oxygen level in the arterial blood.
The sources mention the Rome mnemonic. How does that help?
It's a quick way to think about the primary acid-base problem. Respiratory opposite. In respiratory problems, the pH and COMO move in opposite directions. If QO goes up, pH goes down, acidosis, and vice versa. Metabolic equal. In metabolic problems, pH and HCOs move in the same direction. If HCOs goes down, pH goes down, acidosis, and vice versa.
Okay, that simplifies it. And then you look for compensation.
Right. Is the body trying to fix the problem? Like if you have metabolic acidosis, or your lungs blowing off more KO euros to compensate? And of course, you always check the PaEO to see if the patient is hypoxic, not getting enough oxygen.
Knowing the normals is essential then. pH 7.35 to 7.45.
KO 35 to 45.
Bicarb 22 to 26.
And PaRO 80 to 100. Yeah, you got to know those cold.
So speaking of low oxygen hypoxemia, there are signs you can see even without an ABG, right? Early signs.
Definitely. Early on, the body's trying to compensate. So you might see restlessness, anxiety, maybe a fast heart rate tachycardia. The patient just doesn't seem right.
And if it gets worse, the late signs.
That's when you see cyanosis, the bluish color. The heart rate might actually slow down bradycardia, which is a really bad sign. Confusion, low blood pressure, things are failing.
Diagnosis confirmed by pulse ox less than 90%. Or PaROs less than 80 on the ABG.
Correct. And if it's not treated, the complications are severe. Cardiac arrest, organ failure, hypoxia, kills.
Okay, another critical respiratory issue, pulmonary edema. Fluid filling up the lungs.
Yeah, often due to heart failure, but other causes too. The sources highlight some dramatic features. Crackles when you listen to the lungs.
That classic pink frothy sputums.
That's a very specific sign, yeah. Severe shortness of breath. especially when lying flat orthopnea. Rapid breathing, tachypnea, anxiety. Sometimes you hear an extra heart sound, an S3 gallop.
Diagnosis: chest X-ray.
Chest X-ray showing infiltrates, often in a batwing pattern. A high BNP blood test points towards heart failure as the cause. And the ABG will show hypoxemia.
Treatment focuses on getting that fluid off and helping breathing.
Right. Oxygen first. Diuretics like furosemide, Lasix are key to pull off fluid. Morphine can help ease breathing and anxiety. Vasodilators might be used to reduce the workload on the heart. And you're monitoring intake and output very closely, keeping the head of the bed up.
Complications can escalate quickly to respiratory failure, needing a ventilator.
Yes, or dangerous heart rhythms, arrhythmias, or even cardiogenic shock where the heart just can't pump effectively anymore.
Related, but sort of a different mechanism, is ARDS, acute respiratory distress syndrome.
ARDS is a really severe form of acute lung injury. Widespread inflammation, leaky capillaries in the lungs, fluid floods the air sacs. The hallmark, the defining feature, is refractory hypoxemia, meaning their oxygen levels stay dangerously low even when you give them very high concentrations of supplemental oxygen. The lungs are just too damaged to get oxygen across.
Other signs:
You see a big increase in the work of breathing. They're struggling. Crackles in the lungs, fast breathing. The sources describe bilateral infiltrates on the chest X-ray, often called a whiteout.
Diagnosis often uses that PAO-FeO ratio.
Yeah, the PF ratio. It compares the oxygen level in the blood, PaO-Euro, to the fraction of oxygen in the air they're breathing.
Euros.
In ARS, it's low, less than 300, showing that impaired oxygen exchange.
Treatment sounds tough.
It is. Oxygen, definitely.
Yeah.
Mechanical ventilation is usually required, often needing PEEP-positive end expiratory pressure to help keep those stiff, fluid-filled air sacs open at the end of exhalation.
PEEP helps recruit lung volume.
Exactly. You also have to treat whatever caused the ARDS, like sepsis, pneumonia, trauma. Prone positioning, turning the patient onto their stomach, often helps improve oxygenation significantly in ARDS. And careful fluid management is critical. You don't want to overload them.
Complications of ARDS.
Barotrauma, lung damage from the ventilator pressure. Multi-organ failure, because the whole body is affected by the inflammation and lack of oxygen. And VAP ventilator-associated pneumonia is a big risk, too.
Prone positioning, while helpful, isn't simple, right?
No, it's complex, requires a team, careful coordination. And there are contraindications like unstable spine fractures or high pressure inside the skull.
Okay, one more in this breathing section. Pulmonary embolism, PE, a blood clot in the lung.
Often travels from a deep vein thrombosis, DVT, in the leg. The sources describe a sudden onset of symptoms. Sudden shortness of breath is classic. Sharp chest pain, often worse with breathing pleuritic pain. Tachycardia, fast heart rate.
Sometimes coughing up blood.
Hemoptysis, yes. Hypoxia, anxiety. It's frightening for the patient.
Diagnosis, how do you confirm it?
A D-dimer blood test can help rule it out if it's negative, but it's not specific. The gold standard, according to the sources, is a CT angiogram or CTA scan, which visualizes the pulmonary arteries. VQ scans are another option. ABGs will show hypoxemia.
Treatment, anticoagulation.
Immediately. Usually start with heparin or a similar anticoagulant to prevent the clot from getting bigger and new ones from forming. Oxygen, of course. If it's a massive PE causing shock, thrombolytics, clot-busting drugs might be used.
And IVC filters.
An IVC filter might be placed in the inferior vena cava if the patient can't take anticoagulants to catch clots traveling up from the legs.
The risks with PE are serious.
Very serious. Death, shock, right heart failure, because the heart struggles to pump against that blockage in the lungs. Quick recognition and treatment are absolutely vital.
Okay, let's shift into some more specific respiratory and thoracic care points, especially in the ICU. This one's tricky. How do you assess pain if your patient is paralyzed, maybe on a ventilator with muscle relaxants?
Yeah, they can't tell you, they can't point, they can't even move purposefully. The source emphasizes you cannot rely on movement. You have to become a detective, looking for other clues.
Like vital signs.
Exactly. A sudden jump in heart rate or blood pressure can be a sign of pain. Look for subtle behavioral cues, too. Maybe grimacing, even slightly. Sweating diaphoresis, tearing up, maybe some restlessness if the paralysis isn't absolute.
Are there specific pain scales for this?
Yes, there are validated scales like the CPOT, Critical Care Pain Observation Tool, or the BPS, Behavioral Pain Scale, that rely on observing these nonverbal indicators. You have to use the right tool.
That makes sense. You have to read the body's other signals. Okay. Once a patient is intubated tube in the airway, hooked up to a ventilator, What are the absolute first crucial steps?
Confirmation of placement. You absolutely must know that tube is in the trachea, not the esophagus. The sources list the key methods. End tidal, QO detection is primary. If you're getting QO back, you're in the airway.
Listening to breath sounds.
Listening over both lungs should be equal, and over the stomach should be quiet. And then a chest x-ray to confirm the depth, make sure it's not down too far in one bronchus.
Then secure it.
Secure it really well. An unplanned extubation is a disaster.
Ongoing care after intubation.
Constant monitoring. Vitals, oxygen saturation, CESPIORO. Listen to breath sounds regularly. Check that tube position hasn't shifted. Sedation and pain control are essential for comfort and synchrony with the ventilator.
And preventing complications.
Big focus. Meticulous oral care is huge. Keeping the head of the bed elevated 30 to 45 degrees helps prevent aspiration, suctioning secretions as needed, all aimed at preventing VAP.
Ah, yes, VAP, ventilator-associated pneumonia. Let's talk prevention strategies from the sources. Head of bed elevation we mentioned.
HOB 30-45 degrees, yes. Rigorous oral care, often with an antiseptic like chlorhexidine. Regular suctioning of secretions. Daily sedation vacations. Lightning sedation to assess neurostatus and readiness to wean are important.
Hand hygiene, obviously.
Absolutely critical. And some specialized endotracheal tubes have an extra port for subglottic suctioning, allows you to remove secretions that pool above the cuff before they can be aspirated. These bundles of care really reduce VAP rates.
And the longer you're on the vents.
The higher the risk of VAP, definitely.
Okay, here's a positioning strategy mentioned. Good lung down. What's that about?
Right. This is used when a patient has a problem mainly in one lung, like pneumonia just on the right side, or atelectasis, collapse on the left. You position the patient so the healthy lung, the good lung, is dependent as lower down.
Why does that help?
Gravity. Blood flow naturally goes more to the dependent parts of the lungs. So by putting the good lung down, you increase blood flow, perfusion, to the area of the lung that's actually working well and capable of oxygenating the blood. It helps match ventilation and perfusion better.
Clever. Leveraging physics. Okay, ventilators and their alarms. Fundamental stuff. The two main types. High pressure and low pressure.
Exactly. High pressure alarms mean something is blocking the air from getting in easily. Could be the patient biting the tube. Could be thick secretions plaguing the airway. The tubing could be kinked. The patient might be coughing or bucking the ventilator.
What's the first thing you do?
Always assess the patient first. Look at them, listen to their lungs. Then check the equipment, the tubing. Ignoring a high-pressure alarm is dangerous. It can lead to barotrauma, lung injury from too much pressure.
Okay, and low-pressure alarms.
That usually means there's a leak or a disconnection somewhere. The air isn't meeting resistance. Maybe the ventilator tubing popped off, maybe there's a leak in the circuit, or maybe the cuff on the endotracheal tube inside the trachea is deflated, letting air escape back up.
Action.
Same principle.
Yeah.
Check the patient first. Make sure they're okay. Then trace the circuit from the ventilator to the patient, looking for the disconnection or leak. The risk here is hypoventilation. The patient isn't getting the intended breaths.
And the golden rule from the sources.
Never, ever just silence an alarm without figuring out why it's going off and fixing the problem. That alarm is your safety net. It's telling you something is wrong, potentially life-threateningly wrong right now.
Such a critical point.
Okay.
Let's tackle chest trauma. Pneumothorax, collapsed lung.
Right. Air gets into that pleural space between the lung and the chest wall. The lung collapses down. Key signs are shortness of breath, decreased or maybe absent breath sounds on that side. Sometimes the chest sounds hyperresonant, sort of drum-like when you tap it.
Diagnosis, usually clinical plus CXR.
Yeah. Treatment often involves putting in a chest tube to suck the air out and let the lung re-expand. Oxygen, of course. And watch for subcutaneous emphysema, that crackly feeling under the skin if air leaks into the tissues.
But then there's tension. Pneumothorax, that's a different beast entirely.
Oh, absolutely. This is a true, immediate, life-threatening emergency. It's a pneumothorax where air gets into the pleural space but can't get out, like a one-way valve.
So pressure builds up.
Massively. With every breath, more air gets trapped, increasing the pressure inside the chest. This pressure pushes the heart, the trachea, the great vessels over to the opposite side. That compromises blood return to the heart, causing shock.
Key signs are dramatic.
Very severe respiratory distress. Tracheal deviation away from the affected side. That's the classic critical sign. Distended neck veins, JVD. Hypotension, low blood pressure. Absent breath sounds on the affected side. Tachycardia.
Diagnosis is clinical. You don't wait for x-ray.
Absolutely not. You see those signs, you act. Waiting for an X-ray can be fatal. The emergency treatment is immediate needle decompression.
Where?
The sources specify the spot. Second intercostal space, midclavicular line. You insert a large bore needle to let that trapped air escape immediately, relieving the pressure. Then, a chest tube is inserted afterwards for definitive treatment.
Without that immediate decompression.
Cardiac arrest, shock, death. It's incredibly time-sensitive.
Okay, so chest tubes themselves. What are the key care principles the sources mention?
All right, first, the drainage system must always be kept below the level of the patient's chest. Gravity is your friend here.
Tubing?
Make sure it's not kinked, no dependent loops where fluid can collect and block drainage. Monitor the drainage constantly, how much is coming out, what color is it bloody, pus-like, clear?
Air leaks?
Check the water seal chamber for bubbling. Continuous bubbling usually means an air leak somewhere, either from the patient's lung or the system itself. Assess the patient too. Check for subcutaneous emphysema around the site.
Nursing care essentials.
Keep the dressing at the insertion site clean, dry, and occlusive. Tape all connections securely to prevent accidental disconnection. Encourage the patient to cough and deep breathe. Helps re-expand the lung. Watch for signs of infection.
What can go wrong with the chest tube itself? Potential complications.
Well, it could get pulled out, accidentally dislodged. That requires immediate intervention, usually covering the site with sterile gauze. Infection at the site is a risk. The tubing can get blocked, maybe by clots or fibrin.
And if it gets blocked?
That's dangerous. If it's draining fluid, the fluid backs up. If it's for a pneumothorax and the lung is still leaking air, blocking the tube could lead to a tension pneumothorax developing. So patency is critical.
Okay. And when it's finally time for removal?
It's usually removed when the air leak has resolved or the fluid drainage has significantly decreased. The process involves having the patient take a deep breath and hold it or hum while the tube is quickly pulled out. An occlusive dressing, often with petroleum gauze, is immediately applied and taped securely on all four sides.
Monitoring after removal.
Absolutely. Monitor closely for any respiratory distress, shortness of breath, drop in oxygen saturation. Listen to breath sounds. A chest X-ray is usually done afterwards to confirm the lung is still fully expanded.
What if they get into distress right after removal?
Call the provider immediately. The pneumothorax might have recurred, and they might need the tube put back in.
One more chest trauma point. Flail chest. What's the unique sign here?
Paradoxical chest movement. It's quite striking. This happens when you have several ribs broken in two or more places, creating a free-floating segment of the chest wall.
So what happens when they breathe?
When they inhale, the negative pressure in the chest sucks that unstable segment inward while the rest of the chest expands. When they exhale, the segment pushes outward. It's the opposite of normal chest wall motion.
Painful.
Extremely painful. You might also feel crepitus, that grating feeling of broken bone ends rubbing together. Diagnosis is usually clear on chest X-ray.
Treatment.
Oxygen is key. Aggressive pain management is crucial so they can breathe adequately despite the pain. Sometimes, if respiratory failure is severe, they need intubation and mechanical ventilation to stabilize the chest wall internally. And you have to watch closely for associated injuries like pulmonary contusion or pneumothorax. Respiratory failure is the main complication.
Okay, great. Let's change gears again. Endocrine and fluid balance issues that can become critical, starting with thyroidectomy complications, removing the thyroid gland.
Big potential issues here. The sources highlight airway compromise first and foremost.
Why?
Swelling in the neck or, more dangerously, a hematoma bleeding under the skin can compress the trachea. So having an emergency airway kit, including a tracheostomy tray right at the bedside, is absolutely non-negotiable post-op.
What else?
Hypocalcemia, low calcium. The tiny parathyroid glands, which control calcium levels, sit right behind the thyroid and can easily be injured or accidentally removed during the surgery.
So you have to watch calcium levels closely.
Very closely. If calcium drops too low, it's dangerous. You need to know the signs. Tingling, especially around the lips and in the fingers, paresthesias, muscle cramps, twitching, tetany, involuntary muscle spasms.
Trostex and Trousseau's sign.
Those are specific physical exam signs. Trostex is facial muscle twitching when you tap the facial nerve. Trousseau's is a carpal spasm. The hand and wrist flex involuntarily when you inflate a blood pressure cuff on the arm.
Severe hypocalcemia can cause
seizures or even laryngospasm, that vocal cord spasms shut, closing off the airway. That's a dire emergency. On an EKG, low calcium can cause a prolonged QT interval, increasing risk for arrhythmias. You give IV or oral calcium if needed.
Other risks after thyroidectomy.
Damage to the recurrent laryngeal nerve, which controls the vocal cords, that can cause voice changes, hoarseness, or even airway issues if both nerves are affected. So assessing their voice post-op is important, and of course monitoring the incision site for bleeding.
Okay, now let's contrast two opposite problems with the adrenal glands and cortisol. Cushing's versus Addison's.
Right. Cushing's syndrome is too much cortisol. Addison's disease is not enough.
Cushing's signs are pretty distinctive, right?
Very. The sources paint that classic picture. The moon face, rounded face, purple stretch marks, striae, often on the abdomen, a fat pad on the upper back, the buffalo hump. Truncal obesity fat collects around the middle, but arms and legs are thin.
Skin changes.
Thin skin, bruises easily. Patients often have high blood pressure, high blood glucose, like steroid-induced diabetes, and muscle weakness.
Labs reflect the excess cortisol.
High cortisol levels, yes. High glucose, often low potassium and high sodium. Treatment depends on the cause. Maybe surgery for an adrenal or pituitary tumor, maybe adjusting steroid medications if that's the cause. Management involves monitoring glucose, potassium, blood pressure, and being super vigilant about infection risk.
Why infection risk?
Because all that excess cortisol suppresses the immune system, so preventing infection is key. Other complications include osteoporosis, diabetes complications, fluid overload.
Okay, and Addison's? The opposite, not enough cortisol.
Exactly. The signs are often more vague initially. Weakness, fatigue, low blood pressure, hypotension, weight loss. That characteristic hyperpigmentation, a bronze-like darkening of the skin, especially in creases, scars, and gums, and often a craving for salt.
Labs show the deficiency.
Low cortisol levels, often low sodium, high potassium, and sometimes low glucose. Treatment is hormone replacement, giving steroids, primarily hydrocortisone, to replace the missing cortisol. They also often need extra salt and fluids. Monitoring vitals and electrolytes is crucial.
Which brings us to adrenal crisis, or Addisonian crisis. That's the emergency state.
Yes, a life-threatening emergency. It happens when someone with Addison's or someone whose adrenals are suppressed from long-term steroid use experiences a sudden, severe drop in cortisol levels.
What triggers it?
Stress, like a severe infection, trauma, surgery. Or, critically, suddenly stopping long-term steroid medication without tapering. The body just can't cope without that cortisol.
What happens?
Profound hypotension, shock, severe dehydration, nausea, vomiting, confusion. The sources are very clear. Immediate aggressive treatment is needed. High-dose steroids like hydrocortisone stat, large volumes of 5e fluids, usually saline with dextrose, to support blood pressure and glucose, and treat whatever triggered the crisis.
Outcome without treatment.
Often fatal due to circulatory collapse. It's a true endocrine emergency.
Okay, sticking with endocrine, let's talk thyroid medications and emergencies. PTU, propylthiouracil.
PTU is an anti-thyroid drug. It's used to treat hyperthyroidism, overactive thyroid, including the severe form, thyroid storm, sometimes used before thyroid surgery to get hormone levels under control.
How does it work?
It blocks the production of thyroid hormones. In hyperthyroidism, labs typically show low TSH, the pituitary signal is suppressed, and high T4, the actual thyroid hormone. PTU helps bring T4 down.
How's it taken? Monitoring?
Orally. Important monitoring includes checking white blood cell counts because a rare but serious side effect is a granulocytosis, a dangerous drop in white cells. And liver function tests, LFTs, as it can cause liver toxicity, needs to be taken consistently.
And thyroid storm, also called thyrotoxicosis. That's severe hyperthyroidism.
Yes, a life-threatening exaggeration of hyperthyroid symptoms. Signs are extreme. Very high fever, heart racing incredibly fast, marked tachycardia, severe agitation, delirium, confusion, nausea, vomiting, diarrhea.
Labs show really high thyroid levels.
Very high T4, very low TSH. Treatment is urgent and aggressive in an ICU setting. Anti-thyroid drugs like PTU or methimazole, beta blockers like propranolol to control the dangerously high heart rate and other sympathetic symptoms, cooling measures for the fever, 5e fluids, supportive care,
Complications.
dangerous arrhythmias, heart failure, and potentially death if not treated promptly.
Okay, switching to the other extreme, hypothyroidism. Levothyroxine is the standard treatment.
Yes, synthetic T4. Used for everyday hypothyroidism and also for the emergency state, myxedema coma.
Labs for primary hypothyroidism.
Typically high TSH, the pituitary is screaming for more hormone, and low T4 because the thyroid isn't responding. Levothyroxine replaces that missing T4.
How's it taken? Key points.
Usually once a day in the morning on an empty stomach for best absorption. It's generally lifelong therapy. The dose is adjusted based on monitoring TSH levels. The sources note you should never stop it abruptly. And you need to watch for signs of hyperthyroidism like palpitations or anxiety if the dose ends up being too high.
And myxedema coma.
Yeah.
The hypothyroid emergency.
Yes, profound life-threatening hypothyroidism, signs of the opposite of thyroid storm. Severe hypothermia, dangerously low body temp. Bradycardia, very slow heart rate. Hypotension, hypoventilation slow, shallow breathing. Altered mental status, progressing to coma. Very high TSH, very low T4, often low sodium as well, hyponatremia.
Go treatment.
Needs ICU care. 4V levothyroxine to rapidly replace hormone levels. Active warming measures, warming blankets, etc. Airway support is often needed, possibly mechanical ventilation. 4V fluids, often with glucose. Like adrenal crisis, it's extremely serious with high mortality if not recognized and treated fast.
One more thyroid treatment, radioactive iodine.
Right, RAI. Used sometimes for hyperthyroidism, to destroy overactive thyroid tissue, and certain types of thyroid cancer, to ablate remaining tissue after surgery.
How's it given? Key precautions.
Usually as a single capsule or liquid taken orally. Because it's radioactive, safety precautions are paramount afterwards. Patients need to drink plenty of fluids to help flush out excess RAI, and radiation precautions are needed for a period, sometimes weeks. Avoiding close or prolonged contact, especially with children and pregnant women. Using separate utensils, towels. Flushing the toilet twice after use. Specific instructions depend on the dose given.
Side effects.
The main intended effect for hyperthyroidism treatment is often delayed hypothyroidism, which then needs treatment with levothyroxine.
Okay, let's wrap up endocrine fluids by contrasting SIADH and DI, both related to ADH, antidiuretic hormone, but opposite problems, right?
Exactly. ADH tells the kidneys to hold on to water. SIADH is syndrome of inappropriate antidiuretic hormone, meaning too much ADH. DI is diabetes insipidus, meaning not enough ADH action.
So SIADH means the body holds on to too much water.
Correct. The kidneys retain excessive water, which dilutes the blood. Signs include low urine output despite normal fluid intake, weight gain from the fluid retention, and as the sodium gets diluted down, hyponatremia, you see neurological symptoms. Confusion, lethargy, muscle cramps, potentially seizures if it's severe.
The labs are key here to differentiate.
Absolutely. In SIADH, serum sodium is low, dilutional hyponatremia. Serum osmolality is low, blood is dilute. But paradoxically, the urine is inappropriately concentrated. High urine osmolality and high urine sodium. The kidneys are holding water, but still dumping some sodium.
Main treatment for SIADH.
Fluid restriction. That's the cornerstone. Limiting free water intake helps the body correct the dilution. Sometimes medications like demeclocycline are used. If sodium is dangerously low, causing seizures, hypertonic saline, concentrated salt solution, might be given IV, but very carefully and slowly.
Why carefully?
Because correcting chronic hyponatremia too quickly can cause a devastating neurological injury called osmotic demyelination syndrome, used to be called central pontine myelinolysis. It damages nerve fibers in the brain. So slow, controlled correction is crucial.
Okay, and DI, diabetes insipidus, not enough ADH action.
Right. Either the pituitary isn't making enough ADH, central DI, or the kidneys aren't responding to it, nephrogenic DI. Either way, the kidneys can't conserve water.
So they lose massive amounts of water.
Exactly. Signs are polyuria passing huge volumes of very dilute urine, liters and liters a day. Polydipsia intense, constant thirst. If they can't keep up with drinking, they get severely dehydrated, leading to hypotension, tachycardia, confusion.
Labs are the opposite of SIADH.
Pretty much. Serum sodium is high, hypernatremia, because they're losing free water. Serum osmolality is high, blood is concentrated, and the urine is very dilute. Low urine-specific gravity, less than 1.005 typically. Low urine osmolality.
Treatment.
For central DI, you replace the missing hormone with desmopressin, DDAVP, a synthetic form of ADH. It can be given IV, intranasally, or orally. You also need to replace the fluid deficit, often with hypertonic fluids. Careful monitoring of weight, intake and output, and serum sodium is essential.
Complication of treatment to watch for.
If you give too much desmopressin or fluids, you can overshoot and cause water intoxication, leading to hyponatremia. So again, careful monitoring and titration of treatment are key.
Okay, finally, let's touch on something specific to the ICU environment itself. ICU delirium.
Yeah, a really common and significant problem in critically ill patients. It's an acute state of brain dysfunction.
What does it look like?
It can vary.
Yeah.
Sometimes it's hyperactive agitation, restlessness, hallucinations. Sometimes hypoactive lethargy, quiet confusion, withdrawn. Often there's a fluctuating course, and disturbances in the sleep-wake cycle are very common. Difficulty focusing attention is a core feature.
How is it managed? It's not just about medications, right?
No, definitely not. While meds might be needed for severe agitation, the focus is really on non-pharmacological strategies, often bundled together. Things like frequently reorienting the patient, promoting normal sleep-wake cycles, minimizing noise and light at night, encouraging activity during the day.
Early mobility.
Huge. Getting patients moving as soon as safely possible, minimizing sedation, using the lowest effective dose, having daily sedation interruptions, managing pain effectively, encouraging family presence and participation in care. Familiar faces can be very grounding, correcting sensory deficits, making sure they have glasses and hearing aids if needed.
So it's really about optimizing the environment and care practices.
Exactly. Preventing and managing delirium is a team effort focused on normalizing the patient's experience as much as possible within the ICU setting.
And why is it so important to address?
Because ICU delirium is linked to worse outcomes. Longer ICU and hospital stays, increased risk of complications, higher mortality rates, and even long-term cognitive impairment after discharge. It significantly impacts recovery.
Wow. We've really covered a lot of ground today. From those metabolic crises like DKA and HHS, through major airway and breathing emergencies, chest trauma, ventilator management.
And into those critical endocrine and fluid balance issues like thyroid storm, adrenal crisis, SIADH, DI, and finishing with ICU delirium. It's a broad sweep of critical care concepts.
And it felt like we really did manage to cut through some of the complexity, pulling out those key signs, the diagnostic clues, the essential treatments, and those really critical complications, all based on the source material.
Yeah, hopefully distilling it down. Because understanding these core principles isn't just about, memorizing lists. It's about seeing the patterns, connecting the dots, being able to spot those early warning signs.
And understanding why a specific treatment is used, why fluids first here, why insulin there, why slow correction is vital sometimes.
Exactly. And appreciating just how interconnected everything is, how delicate the body's balance can be when it's under severe stress.
It really gives you that bigger picture. So maybe something for you, the listener, to think about. How does really understanding the fundamental differences, like the specific metabolic problem in DKA versus HHS, or the opposite water issues in SIODH versus DI, how does that change the way you think about these conditions, or even just approach patient assessment?
Or maybe reflect on how something like ICU delirium shows that deep link between severe physical illness and how our brain functions under stress. It highlights that we have to care for the whole person, mind and body, especially when they're critically ill.